In this presentation, we shall look at the key differential diagnosis in a 20-year-old who presented with primary amenorrhea. Her height was 1.6. Breast development was Turner 1, while axillary and pubic hair development were Turner 2 to 3. Vaginal length was approximately 8 centimeters. Pelvic ultrasounds demonstrated a hypoplastic uterus with no ovaries visualized. So, this is a shield, and this is the chest of the patient. Appearing more like a chill or shield chest described in cases of Turner syndrome. Note that the normal internipple distance is about 18 to 22 centimeters, but here you can see this is more than 22 centimeters. So widely spaced nipples. So let's look at the zoom out video. This is the bladder. You can see the vagina here. Some secretions within the vagina. And look at the hypoplastic uterus. Just assume the normal shape of the uterus, which is pear shape, but it's hypoplastic. Free fluid, the peritoneal cavity, you can see the hypoplastic uterus, normal length of the vagina here. No ovaries were visualized. Since she's a virgin, a transrectal ultrasound would have been more appropriate, but the prop is faulty. So one has to do with what is available, which is a trans-abdominal prop. So look at the measurements of the uterus. 1 by 0.6 by 1. Some of the renal complications are associated with tonus, horseshoe kidney, and malrotation or duplication anomalies. But here you can see both kidneys are normal and in their normal positions. So now, what is or are the most likely differential diagnosis in this case? Stewart syndrome is pure gonadogenesis. Is it a possibility? Yes. Because here you can see breast development of standard 1, pubic development, and axillary here development are normal. Then you have a rudimentary uterus. Ovaries would be strict, but here they were not seen. And of course, the phenotype here is female. There was no breast, there was a uterus, nobody seen. So yes, this is an important differential diagnosis. What about tonus mosaic? Is it a possibility? Yes, it is. Why? Because in tonus mosaic also have absent or poor breast development with normal pubic development, a rudimentary uterus, also strict gonads. But in tonus mosaic, the height may be normal, and here the patient was 1.6 meters. So this again is a strong differential diagnosis. What about Mayer-Rokitansky? No, it's unlikely, because in Mayer-Rokitansky, the breast development is normal. Ovaries are present. So this is not a possibility in this patient. What about 17 alpha hydroxylase or 1720 lyase deficiency? This one is commonly present with ambiguous genitalia, and here the genitalia wasn't ambiguous, so it's an unlikely possibility. Could it be a case of androgen insensitivity syndrome? No. In androgen insensitivity syndrome, you have normal breast development due to aromatization, and what you have as gonad is a testis, so uterus will be absent. So this is not a case of androgen insensitivity syndrome. Is it possible that is a central problem of hypogonadotrophic hypogonadism? It's unlikely, because here the ovaries were not seen at all. Although of course the uterus can be infantile here, but not rudimentary or hypoplastic. So this is an unlikely differential diagnosis. What about Turner syndrome? It's unlikely. Why? Because Turner syndrome is commonly, almost always, associated with short stature. This patient was 1.6 meters. So it's unlikely to be a case of Turner's. So the most likely possibilities here are Turner's mosaic or CY syndrome. But I would rather go with mosaicism because of the shield chest and widely spaced nipples. So these are the most likely diagnosis in the index case. Thank you very much for listening.